afternoon, good evening. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I want to welcome and thank you all for joining us today. My name is Aline Serfari, and I'm here with Dr. Hilary Humans, who coordinates and moderates this series with me. Our guest speakers today are Dr. Jade Anderson, Dr. Marcelo Bordalo, and Dr. Julia Melenevsky. This session will focus on sports imaging. The speakers will present their cases, and at the end, we'll have a Q&A session, like every month. If you have questions at any time during the presentations, please put them in the chat box, and at the end, the speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. If you want to join the OCAD community and see challenging cases, consider registering on the OCAD website. And just a quick reminder, attendees have not been given the permission to screen record any of these presentations as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you for your understanding. And with that, Hilary will kick off the session.
Okay, it is my pleasure to introduce my friend, Dr. Jade Anderson, who's an assistant professor in the Department of Radiology at the University of Wisconsin-Madison. She specializes in musculoskeletal imaging and intervention. She completed her medical school training at Boston University in 2016. She actually started out in orthopedics, completing 2 years of orthopedic surgery training at Ohio State University, but then she saw the light and transitioned to a radiology residency at Norwalk Hospital in Connecticut, and followed that up with fellowship training in musculoskeletal imaging and intervention at the University of Wisconsin Hospital and Clinics. Jade enjoys teaching and mentoring medical students. She's passionate about increasing diversity and women within the field of radiology, and is actively involved in healthcare policy and social media engagement for educational content. Her research interests focus on gender and minority health equity. Fabulous, Jade. Share your screen.
Sharing my screen, and then do you see this screen here? Do you see my mouse?
Yes, but you have to go into presenter mode.
Right, and then I have to switch the screens like you told me. So now you see the presentation?
Yes, perfect.
Excellent. Okay. Thank you both to Hilary and Aline for inviting me today. My name's Jade, again, University of Wisconsin, and I'll just jump right in. I do not have any disclosures. So here is our case. She is a gymnast. 8-year-old female vaulter. She's had low back pain for about 4 to 5 weeks prior to her presentation to the ortho clinic. So it was thought to be a low back strain. She had severe pain on the low back and the coccyx, worse with load bearing and extension exercises. And on physical exam, she was tender to palpation, but she was neurologically intact. So kind of what's on your differential when you're thinking about this as a radiologist. So, we're thinking about muscle strains, spondylolysis, discitis, osteoid osteoma, and potentially Oppenheimer ossicles. So these were her initial imaging. We got radiographs of the lumbar spine, AP and lateral with obliques. And then I will take a second, and then I'm going to zoom in and give you another second. And as you notice, there is a lucency within the region of the pars interarticularis, which is consistent with spondylolysis. And in addition, there's evidence of, grade 1 anterior listhesis of L5 on S1. So our diagnosis is spondylolysis with anterior listhesis of L5 on S1. So the plan from clinic was to basically put her in a sports physical therapy program. She's to rest for 6 weeks, avoid extension and rotational activities, and then the plan will be to obtain an MRI to evaluate for a stress injury if she has no improvement, after this time. So the patient did have improvement, but she did return to clinic about 2.5 years later. She returned with severe right back pain for about 2 weeks' time, which was worse with flexion, extension, sitting in certain positions, and of course, while doing her gymnastics. On physical exam, she was not tender to palpation, and she had full range of motion. So these are our repeat radiographs. Our repeat radiographs are outlined in green, and the old 2.5-year-old radiograph is outlined in red. So I'm going to take a second. And so what you can see is that repeat imaging shows frank spondylolysis with worsening grade 1 anterior listhesis of L5 on S1 when compared to prior. So she presented to the pediatric spine surgeon, and the spine surgeon wanted to get an MRI to assess whether there was acute or chronic spondylolisthesis. So we have sagittal images of the lumbar spine, and these show bilateral pars defects, which are more displaced on the left. We have an additional axial image, which shows asymmetric right bony edema. So this is our osteo, and this is an MRI sequence that's an option for GE. And it basically produces a CT-like image, and it really showcases the bilateral pars defects nicely, which you can see here as they come across and here. So this is great for pediatric or pregnant patients when you want to limit radiation exposure. And ZTE stands for 0 TE. So there's a sharp contrast between cortical bone and the surrounding soft tissues. So pars interarticularis, or pars for short, these lie between the superior and inferior articular processes bilaterally of the vertebrae. And this region bears the highest stress load when you're in extension and flexion. On radiographs or fluoroscopy, the pars interarticularis is best seen in the Scotty dog view. But radiographs have a very low sensitivity for identifying pars defects. So CT is actually the gold standard. However, CT is not great because of the radiation exposure, especially in pediatric patients. So again, this is an numbered Scotty dog view on radiographs, and the number 4 is where your pars interarticularis is. So etiology and epidemiology. The cause of pars defects are debatable. The best theory at this time is that it's due to repetitive mechanical stress. And there's a 5% incidence in adolescents and adults. Whites are actually 2 to 3 times more likely to have a pars defect when compared to Black patients, and males are 2 to 3 times more likely to have them when compared to female patients. So if you see a pars defect on radiograph, 25% of the time, there will be associated spondylolisthesis. And there is a strong association with spina bifida patients. So this graph shows the proportion of spondylolysis and where it occurs. So 71 to 95% of spondylolysis occurs at L5, and 5 to 23% occurs at L4. It really doesn't like to occur between L1 and L3. So this is a review article that looked at the incidence and kind of what sports were associated with pars interarticularis defects. And this is out of Australia, and which English influence. So diving was actually the most common at around 36%, cricket around 32%, baseball and softball 27%, and so forth. This is another systematic review article which discussed imaging pediatric spondylolysis. And so the average sensitivity of MRI with identifying spondylolysis when you used CT as a reference was around 81.4%. When you use SPECT as a reference, the average sensitivity of CT was 85% and MRI was 80%. When you compared a 2-view radiograph to bone scans actually had 7 to 9 times effective radiation dose, and 4-view radiographs in a CT only had about 2 times increased radiation dose. So their recommendation from this was actually that a 2-view radiograph is best for initial imaging due to efficacy, low cost, and lower radiation exposure. This is an example of a SPECT scan from our institution. So Incidentally, these were actually called pars defects, but if you take a closer look where my arrows are, these are actually stress fractures of bilateral pedicles. And again, this is at L2, so this is a rare location for pars defects as well. So on the far right, you can see that there's increased uptake at those pedicles, and that's that SPECT image on the far right. So for treatment, so conservative treatment is always first line for spondylolysis. You do a combination of bracing, activity restriction, which is difficult in children, NSAIDs for pain control, and then physical therapy. And the most important part of this is honestly the physical therapy. And so you stop all pain-producing activity for at least 6 weeks, and then you do a back exercise program that can help lower the rate of refracture. It's also been shown that LIPUS, or low-intensity pulsed ultrasound, has recently emerged with promising results for increasing kind of bony rates across the lysis. And this has shown reduced time required to return to sport by almost 72%. There was a 2016 review that found that athletes returned to play at 3.7 months on average, and non-union may not negatively impact their short-term outcomes. This is probably due to a fibrous union that kind of goes across that lysis site, which stabilizes the defect and reduces pain. An additional study from this paper demonstrated that 64% of progressive defects with pedicle edema actually healed by 3 months when compared to 27% of those without pedicle edema. So in our patient, on the right, she had pedicle edema, so that's more likely to heal than the one that was on the left. So operative treatment. So 5% of athletes fail conservative treatment, athletes. And indications for operative treatment include persistent pain after 6 to 12 months, neurologic deficits, or worsening symptomatic spondylolisthesis. Positive clinical outcomes are usually unilateral defects and a patient of younger age. And then there's multiple techniques, but that's not within the purview of this talk. These are my references, and this is my contact information. And now I have to figure out how to stop sharing.
Thank you. That was wonderful. Okay. Aline, take the screen. What just happened?
I think you're muted, Aline.
Aline, you're muted. Aline, you're muted.
Oh, I know it was not allowing me. So now Milene allowed me to unmute me. Okay, so now it's my turn to introduce my dear friend, Marcelo Bordalo. He completed medical school, a radiology residency, and a musculoskeletal fellowship at the University of São Paulo. Additionally, he completed fellowships at the MSK department of the Université Catholique de Louvain in Belgium, and at the Hospital for Joint Diseases in New York. He holds a PhD from the University of São Paulo. Formerly, he was the director of MSK Radiology at Hospital das Clínicas in São Paulo, and Hospital Sírio-Libanês, also in São Paulo. Currently, he is the chief of radiology at Hospital Orthopedic and Sports Medicine Hospital in Doha, Qatar. And he's a member of the ISS and currently serves as a member at large on the executive committee. He's also the book editor of the MSK volume of the Brazilian College of Radiology book series, and he has authored and co-authored several book chapters and more than 100 peer-reviewed articles. With that, please, Marcelo, share your screen.
Thank you, Aline, for the introduction. Let me share. Okay, do you see my screen?
Yes.
Okay, so thank you, Aline. Thank you, Hillary, for the invitation to talk in the OCAD and Rio de Janeiro Radiology Society MSK series. It's really a pleasure and an honor to be here. And I'm gonna show one case. If there's time, I'm going to show another case, okay, on one topic, which is nerves in some athletes. So we see some nerve injuries also in some athletes. I'm going to show a little bit of our experience here, specifically in the elbow. So we have a weightlifter presented with a medial elbow pain and clicking while extending the elbow. Clinically, he had a suspicion of an ulnar nerve neuropathy and a possible dislocation. So an ultrasound was ordered initially for evaluation. So this is the dynamic ultrasound, and we can see here medial epicondyle. We can see in red the medial head of the triceps, and in yellow the ulnar nerve here. And here's the medial epicondyle, and you can see with flexion there is dislocation, anterior dislocation beyond the medial epicondyle of the ulnar nerve. We're going to see it now. Both are posterior. This is posterior, this is anterior. Both ulnar nerve and triceps dislocated anteriorly to the medial epicondyle, and now they went back. I want you to look again. So here's the anterior dislocation of both. You can see that when they go back, first the triceps goes back, and then the ulnar nerve goes back. This is important for the diagnosis, the clinical diagnosis. So here you can see both dislocation, anterior dislocation of both. When they start to extend again, first the triceps and then the ulnar nerve surpasses the medial epicondyle. So the interesting features we see in this dynamic ultrasound, the anterior dislocation of both the ulnar nerve and the medial head of the triceps muscle, which is characteristic for a snapping triceps syndrome. In fact, the patient had 2 clicks. He could feel the 2 clicks, and even us doing the dynamic ultrasound could hear the 2 clicks. The first click is when the triceps muscles passes over the medial epicondyle on its way back on the elbow extension to the posterior compartment of the elbow. And the second click was when the ulnar nerve transposes the medial epicondyle back to the posterior compartment of the elbow. So this double click sign on clinical examination was already described in the literature in this radiology paper. And the presence of this double click sign clinically distinguishes the snapping triceps syndrome from the isolated ulnar nerve dislocation. So the snapping triceps syndrome, there is the anterior dislocation beyond the medial epicondyle, the humeral medial epicondyle of the triceps and the ulnar nerve while doing the elbow flexion. And the click is heard when the elbow is extended again, and first the triceps goes back to the posterior compartment, and second the ulnar nerve goes back to the posterior compartment. And what about MRI? Does it have a role in snapping triceps syndrome? Of course, ultrasound, the dynamic ultrasound is mostly indicated, is the most indicated option because of the facility performing dynamic evaluation. However, we can perform MRI also. So this is the MRI from this patient. Actually, this was done first, primarily. And we can see here the ulnar nerve in its normal position at the cubital tunnel, and also the medial head of the triceps muscle. Okay, of course, the MRI is done with the extension, and dislocation is not seen on most cases of regular MRIs. But we can see this increased muscle volume in the topography of the medial head of the triceps, which might be a hint for a snapping triceps syndrome, of course, along with the clinical symptoms. So in order to visualize the dislocation on MRI, we need to perform image acquisition with elbow flexion. This is possible with the big gantries we have today, with the flexible coils. Today we have the air coils on GE. So it's easy to do these flexions of the elbow. And we did in this patient, we call him back to do this flexion, and we can see the ulnar nerve dislocated. So we have to look at the apex of the humeral medial epicondyle. If the ulnar nerve transpasses the apex, this is dislocation. And we can also see the medial head of the triceps muscle also dislocated anteriorly on the MRI. So what is the difference with the simple ulnar nerve dislocation, with the isolated ulnar nerve dislocation compared to the snapping triceps syndrome? So here on MRI, in this case, we can see the nerve is minorly subluxed anteriorly. Here, actually, he's at the apex of the medial humeral epicondyle here. This is a normal extension, elbow extension MRI. You don't see the muscle mass, the triceps muscle mass, as we saw before. And on dynamic ultrasound, we can see here ulnar nerve in yellow. You can see it dislocating anteriorly compared to the medial epicondyle, and you can see the triceps muscle mass. It remains at the posterior compartment. Here you see this is the muscle mass for the triceps. It remains in the posterior compartment. So no triceps muscle dislocation. Another case, we can see in yellow, the ulnar nerve dislocated anteriorly. Now it went back to the posterior compartment. Here in red, the triceps. With the elbow flexion, you can see the ulnar nerve dislocating anteriorly, and the triceps muscle remains in the posterior compartment. So this is an isolated ulnar nerve dislocation. So in summary, the snapping triceps syndrome is the anterior dislocation of the medial head of the triceps muscle over the medial epicondyle along with the ulnar nerve. And on clinical examination, we have the double click sign, which differentiates from the isolated ulnar nerve dislocation. And dynamic ultrasound is the imaging study of choice, and MRI with elbow flexion is also an option. I think we have time. 7 minutes, we did the first case, so I think we have time to show another interesting case also on the elbow. So this is a shooter, a professional shooter, who presented with weakness of the hand and wrist muscles. As previous history, this patient had an ulnar nerve decompression at, a median nerve, not ulnar nerve, a median nerve decompression at the wrist, at a carpal tunnel 1 year ago with no improvement in symptoms, okay? He did this MRI to evaluate this non-improvement in the symptoms of the wrist to see if there was something wrong with the surgery. Apparently, there is a satisfactory median nerve decompression here. You can see the flexor retinaculum is decompressed. There's no fibrous tissue here. So apparently on imaging, it looks like a satisfactory surgery. On clinical examination, this patient had weakness of the hand and wrist muscle. So you can see here, while flexing the thumb, there is weakness on this hand, which means weakness of the flexor pollicis longus. And of the fingers, you can see the normal muscle strength, where the examiner is unable to flex, to extend the fingers. And on the affected hand, you can see the examiner can extend the flexors, the fingers, which means there is flexors, tendon, flexor muscles weakness, okay? Flexor digitory communis weakness. Also on clinical examination, this patient had this positive scratch collapse test. This is a very interesting test, which you see the examiner scratches the suspected area. You see it scratches the elbow. On the normal side, he's unable to internally rotate. But on the affected side, after he scratches the nerve, you can see that there is he is able to internally rotate the elbow, which means a weakness of this muscle. So this means there is some nerve injury or nerve compression at the elbow on the right side. So this is a very interesting clinical examination. I think it's important for us as radiologists to know about this clinical examination. So this scratch test was described by this hand surgeon, Susan McKinnon, in 2008. it is a physical irritant, a scratch of the suspected area of the nerve injury or nerve compression, and it is positive when after the scratch, there is temporary loss of voluntary muscle contraction. Here, I'm going to show another case now, scratch test at the median nerve at the wrist. You can see on the right side, it was positive. Without scratch, it's unable to internally rotate. Scratching, he internally rotates. So this is a bilateral positive scratch test indicating bilateral median nerve compression, in this case at the wrist. Okay? So the clinical hypothesis for our case is Lacerta syndrome. What is Lacerta syndrome? It's a compression of the median nerve at the level of the elbow, at the level when it surpasses the Lacerta's fibrosis. So if you remember the anatomy, the median nerve, it passes at the elbow under the pronator teres in close relation to the Lacerta's fibrosis. And here you can see the relationship of the median nerve with the Lacerta's. Here the Lacerta's extends from the biceps tendon to the pronator teres, and the median nerve passes right beneath the Lacerta's here in this in the elbow. So an MRI was ordered for evaluation of this compression. So we can see here on the medial side pronator teres here on the axial T2. Let's go back. Oh, sorry. Let's go back here. And you can see the median nerve, no abnormality here on the T1, axial T1. And even on the fluid sensitive sequence, you can see the median nerve here, no abnormality. The pronator, no abnormality. The Lacerta's, usually we don't see any abnormality at the Lacerta's as well. Looks good here, no abnormality. However, on the 3D nerve sensitive sequence, we can see increased signal of the median nerve. Now it is approximately, it's normal. And here's the pronator teres. We're going to see it again. Let me show you. So here's the median nerve. You can see thickened with increased signal distally. As it goes proximally, you can see it has a more grayish signal, and even the size is small. So the 3D sequences, images are very important. And this is a MIP reconstruction of this 3D image. You can see here the median nerve proximally, normal size, normal signal, and at the level of the pronator teres and Lacerta's fibrosis, you can see it's thickened and with increased signal. So the Lacerta syndrome was first described in 2013 by Dr. Haggard. And it is considered a commonly missed and misdiagnosed median nerve entrapment at the elbow. It is a clinical diagnosis specifically with weakness of the wrist and hand muscles. 75% is an isolated median nerve compression at the elbow. 25% is an elbow and wrist compression of the median nerve, which is also called the double crush syndrome. And 10 to 20% of the cases have a history of a prior failed carpal tunnel release, indicating that the compression was either only at the elbow or together as a double crush in the wrist and the elbow. And the treatment is first steroid injection, not very useful, and surgery, Lacerta's fibrosis release, either open surgery or ultrasound-guided release. There is no imaging study related to direct visualization of the median nerve on Lacerta syndrome. There is only one study showing muscle signal alterations after post-exercise images showing this diagnosis. So, in fact, Lacerta syndrome is a disputed syndrome that is controversial. That some surgeons don't believe in the Lacerta syndrome. And the great question is there any difference between the Lacerta's and the pronator syndrome? There is no definite answer to this. Clinically, the tenderness at the Lacerta's favors Lacerta syndrome, but it's very difficult clinically to differentiate both. But the pronator syndrome is the compression of the median nerve in between the two heads, the humeral and ulnar head of the pronator teres, as a nutcracker on the nerve, and the Lacerta's is the compression of the Lacerta's over the the median nerve. It's more a dynamic compression as well. There are different surgical treatments for the lacertus release and the pronator teres release, but clinically it's very difficult to make this diagnosis, and this is why I think imaging might help a little bit. And I think 3D sequences are mandatory to make this diagnosis. On normal and fast vehicle to 2D images, we might not see the nerve abnormalities. These were my cases. These are my contacts if you want to contact me, and I want to thank you again for the opportunity.
Crazy cases, Marcelo. I still don't understand the scratch test, but maybe I'll revisit the videotape. Yulia, are you with us? Talk to me. Yulia, turn your video on. Line?
Okay, we can do questions while Yulia.
I'm here.
Oh, you're here.
I'm here. I'm here. I'm here.
Okay.
Here
Okay.
is I'm definitely here. So
That's good.
Okay.
My-
Okay. So,
okay, so we'll see about the video. Hold on one second. It does not want to show me. I don't have any makeup on. Maybe that's it.
the video is not so important as long as are you able to share your screen?
I should be able to. Give me
Let's
one
do
second for that.
Okay.
Here you go. Give me just 1 second. Oh, excuse me. And then just 1 second, okay? This has never happened before.
Oh, now I see you.
Okay, yay.
Okay.
And
So
hopefully the case presentation share, it's gonna take a second. So how about now? See it?
No.
Yet, but it says that you started sharing, but we don't see anything.
Okay. All right. Do you want to do Q&A?
Oh, now we have it. We have it. Okay. We have
got it.
We're
Okay,
ready to go. But
excellent.
let me take
Cool.
a moment to introduce you. So
Okay.
so
And tell them I'm not technologically challenged, okay?
no, far from it. So it's my pleasure and relief to introduce Dr. Yulia Melenevsky. Once again, she's one of the few people I've invited on several occasions because I just love her cases and I think she's a fabulous teacher and she's a good friend. Dr. Yulia Melenevsky completed medical school training in St. Petersburg, Russia. And then, right down the block, she did her residency and MSK fellowship then at Beth Israel Deaconess Medical Center in Boston, Massachusetts. She's currently, I think it's been updated, associate professor at University of Alabama at Birmingham, Alabama, where she's MSK Fellowship Program Director. She's interested in imaging trauma and orthopedic hardware, tumor imaging and intervention, and adult education. So, Yulia, I think we're a bunch of adults. Teach us.
Okay, awesome. Thank you so much, Hillary and Alini, for the invitation. I apologize. I had to do a spondylolischitis biopsy, and the patient's BMI was 56. So we were searching for a long enough needle, did not find one, so I had to abandon it. But good try. I did make decent tries. Okay, so the case presentation. I looked at the cases presented earlier, and now I am a little bit unsure. This one may not be as interesting, but
No.
thank you so much for your presentation. Okay. It's just there's not that much to say about it, but here's the case. I still have no disclosure, sadly. So the clinical information, 23-year-old gentleman presents with left knee pain after injury. He sustained injury in rollover motor vehicle collision. Here in Alabama, we have mean, crazy trauma. So I have all kinds of examples of crazy trauma, and this was, I do think it was fairly crazy. So he went to the ED and presented with face hematoma, but no major injuries. Somehow, he passed through the entire emergency room and got no knee radiographs, which is the first really reportable finding in this case. No knee radiographs done. 2 weeks later, he made it to orthopedic office and was found to have no instability on exam, and he was able to ambulate with moderate pain. The description of orthopedic exam was rather scant. Nurse practitioner performed it, so I'm not really sure if he really had all that. There you go. Here are the radiographs obtained at orthopedist's office. So these demonstrate a joint effusion, pretty dense suprapatellar joint effusion, congenital variant of the patella, and not much else. I would say not much else. Here's an MR that Here's an MR that they obtained following the visit with orthopedic surgeons, and there are definitely some extensive and very interesting findings. He has an osteochondral fracture at that medial femoral condyle. It looks like his lateral retinaculum is torn, and there is a extra-articular, extracapsular collection extending through what looks like joint capsule and lateral retinaculum. Here is a better depiction of the fracture on the T1 coronal image. So all these findings we've got. So we have some other sequences. Okay, here you go. Very sensitive mouse too. On the anterior to posterior coronal fluid sensitive sequences, we've got lateral retinacular tear. There's a big defect. Vastus lateralis tear. Here's the retracted tendon fibers. And IT band looks to be intact. And again, this extracapsular fluid collection. So what could this be? Let's look at some axial images as well. Here they are. So, oh goodness, sorry. So here is it definitely wants to show me as being technologically challenged. Promise it's not me, it's them. So osteochondral fracture at the medial femoral condyle, lateral patellopole contusion, large lateral retinacular defect, and vastus lateralis injury. So the diagnosis we came up with was transient medial patellar dislocation. So I almost fired my end of the year fellow over this because he raised the concern for transient medial patellar dislocation, and I was shaming him into I said, well, that never happens actually. Why did I not teach you anything? So, but turns out it is reported. It is case reported. It is an uncommon entity after all, and classically occurs in the setting of aggressive lateral release because of the loss of vastus lateralis pores. Additional risk factors include patella alta and trochlear dysplasia. And in absence of prior surgery, this is case reportable, really. There's few cases reported in the literature. So since that's in a nutshell, this is my case. So I felt obligated to go over some relevant anatomy of the lateral supporting structures of the knee. Superficially, there is a deep fascia and then longitudinal superficial fibers of the iliotibial band extension to the patella, further abbreviated as ITB patella, and distal quadriceps aponeurosis. So the structures of the lateral supporting mechanism are not as well studied as its medial counterpart, but there are several surgical and radiological papers on that. So this is from one of the sports orthopedics paper. So lateral patellar restraints, they did a very nice dissection. So I'm going to I try to orient myself, and I'm going to try to orient you. This is distal quadriceps, which is here. This is its aponeurosis. This is IT band oblique fibers right here. We do have some transverse fibers. They are lifted up by the instrument, and patella is outlined by little pins, and they're showing us the patella tendon. And this here is a girding tubercle. No worries if you can't, get into it right away. I definitely wasn't. So deep components of the lateral patellar restraints include this ITB patella fibers, its transverse deep fibers, vastus lateralis aponeurosis, and then some capsular ligaments, including lateral patellofemoral ligament, lateral patellotibial ligament, and lateral patellomeniscal ligament. Here, let's see and try to identify them. So here it is, the iliotibial tract, and here are these deep transverse fibers that are a part of the lateral patellar restraining mechanism. Vastus lateralis obliques, so here they are connecting distal quadriceps tendon, iliotibial tract, direct fibers. So this is part of it. Some more images. So these are very robust iliotibial band patella fibers right here. You can see how these are going to be pretty strong. Here it is, the capsule ligaments, so the very deep ligaments can be seen if you obviously open the joint because they are capsular ligaments. Here they are. Okay, so what they did was they everted the patella out of the way. So this is the patella, and this is the lateral femoral condyle. So let's, and this here is a lateral meniscus. So they transilluminated it for us, which I don't know if it helped you. It doesn't help me, but here's what they did. For radiologists, they superimposed images of the femur and patella, and then put some lines for us. So that helps a lot. So let me highlight some things. So number one is lateral patellofemoral ligament, and number two is lateral patellomeniscal ligament. Here you are. Now you could imagine that they are right there. So this is a meniscus, this is a patella, and femoral ligament. So here they are. Again, from another paper, another depiction, these are resected, more resected specimen when the femur and tibia were resected. So here's an iliotibial band, pretty dense fibrous structure, IT band patella ligament. And here it is, they just opened the joint for us, everted the patella, and then we could find lateral patellomeniscal ligament. Meniscus is right there. And femoral condyle is here. As you can see, probably from just looking at them, IT band patella ligament is the strongest of them all. Well, you're going to ask me, well, Dr. Melenevsky, where is the lateral patellotibial ligament that you promised to show us? Well, so while in some radiological literature, they're pretty certain that that exists, in orthopedic literature, there are some controversies about that. The authors that I showed you the dissection pictures from, they don't believe it exists. So they describe it as some longitudinal fibers of the deep aponeurosis level, some saying it's just a thickening of the capsule, and some do describe it as discrete ligaments. So as far as I understand, this is a little bit of controversy. Okay, so with all these descriptions, the authors, particularly this Dr. Amos, he was in his career, he was really concentrating on lateral patellar support structures. And so he came up with what we could see if we were trying to dissect the lateral complex. So first is a deep fascia. These are some arcuate fibers, quadriceps aponeurosis, so they overlie quad aponeurosis, and then iliotibial band patella fibers are right there. Tibial band is back here, and this is lateral patellofemoral ligament, which is the deepest structure. What description of anatomic structures without showing images from Dr. Resnick's paper? This is an image where he shows us that we can see superficial and deep fibers of the lateral retinaculum. Here it is connecting to the IT band. And these are his images. This is an anatomical dissection image. This is a synovium, and he thinks we can see the superficial and deep fibers of the patella retinaculum right there. This is biceps femoris. We have another level, which we can look at. Here it is. So this is an epicondylar patella band. So I'm thinking that surgeons would call it patellofemoral, and here's its attachment right there. Here you go. Superficial and deep. I mean, I know Dr. Resnick could see it in 1997 on my MRIs. The quality is still such that I can't see it. But here it is. We can strive and find that. There's a recent paper, I think it was in skeletal radiology, where they looked at possibility of visualizing deep structures of the patella supporting structures. I want to say it was in skeletal radiology by Dr. Boutin. And I recommend you look at that paper as well, but this is what the surgeon can see. Okay, so the follow-up, patient came back to the sports clinic, off pain medications, no tenderness on exam, occasional swelling, but ambulating fine, and he was discharged to return as needed. So in summary, it is a very uncommon entity, commonly, as far as it's uncommon, but associated with lateral patellar retinacular release in treatment of transient lateral patellar dislocation. If no surgery, it's extremely rare. Like I said, a few case reports. And treatment, they decided, would be similar to lateral dislocation, which is in first-time dislocators without risk factors, such as surgery, is going to be conservative. There are no reported repeat dislocations, especially in the cases of non-surgical transient medial patellar dislocation. I've got some references. More are available if you need them, and I'm happy to answer questions. You're welcome to email me as well. If someone has cases of these, maybe we could do case series. So thank you very much. And
Julia, while you're there, I'll ask you a couple of questions. So I assume there was a normal femoral trochlea, no patella alta. It's not the same kind of predisposition.
So the predisposition is patella alta and shallow trochlea as well, as you would think, but it still doesn't happen unless there's lateral retinacular release. But it still doesn't happen. So the predisposition would be the same. Right?
So I was taught that, I mean, and I've seen cases, the rare case where people present with a patella that's actually still dislocated laterally when they arrive. And if you image them like that, they actually have no translational bone contusions or fractures. And I was told that they get those bone injuries when they relocate because the lateral femur protrudes more anteriorly than the medial. So Do you think that these are really more impaction injuries during dislocation rather than on reentry? Or, I mean, it's just academic.
Well, the contusions are maybe with relocation, but what do you say about the lateral retinaculum?
Oh, no, no, no. That has to rep with, that's allowing the dislocation.
Right. And so I think I do think it was a medial patellar dislocation, and the contusions were on impact.
Yeah.
I do think that because we had no abnormality to the medial supporting structures whatsoever. They were stone cold normal, so I do think that's what it was.
Right.
Even though it's extremely uncommon, but that's why the case is here.
Right. We have a question from Dr. Brown to Dr. Anderson for Jade. Do you think any imaging exams are important in the assessment for an athlete to return to full sports activities? Jade?
Yulia, we can still see your screen, just FYI. No, so
I'm trying.
So I saw that question. I don't think any imaging exams are needed for the athlete to return to full sports activities. Once you kind of complete your therapy and you're not having the pain that you were having before, and you're easing back into your sports activities, so long as your symptoms are controlled, then you don't really need imaging assessment. I would say imaging assessment is when you kind of have that new pain, worsening pain, neurologic symptoms, things of that nature. In fact, that's what I'm actually doing to manage my anterior listhesis and spondylolysis.
It's your question to Marcelo, Hillary, the next one.
Yeah. Dr. Gasseb asked, why is it referred to as Lacertus syndrome if there's no thickening of the Lacertus fibrosis? Do you agree that it's more accurately described as pronator syndrome? What is the relationship with postoperative wrist conditions? Additionally, should dynamic modalities for pronation and supination be utilized?
Yeah, I think it refers also to Hillary's question in the chat box. Actually, I worked with one of the surgeons that described the Lacertus syndrome, Elizabeth Haggard. And before knowing her, I was pronator team. I never believed in this Lacertus thing, but she convinced me. So why? Because the pronator is the compression in the nut, like the nutcracker, when the nerve passes in between the two heads of the pronator. In the Lacertus, you don't have this muscle compression. So basically it's a carpal tunnel at the elbow, the Lacertus syndrome. And with the release of the Lacertus, you can see relief of symptoms. All these patients, they get much better. And if it was pronator syndrome, you wouldn't see this improvement in symptoms because the compression is in between the two muscle heads and not.
But is it just indirectly decompressing the compression between the heads of the pronator? If you
I agree with you.
Lacertus?
I think it's
like
not
a fasciotomy.
direct. Yeah, I think it's not a direct compression of the Lacertus on the median nerve. I think it compresses the pronator, some kind of, I think you have edema, whatever, and then you decompress indirectly the pronator. I totally agree with you. And Elizabeth Haggard also believes in this theory.
Okay. Any other questions?
One more from Eduardo Brown, Dr. Brown, to Marcelo. Do you use DTI?
I never used it, basically because it's a busy department, so we haven't been doing research on the nerve compressions. So straightforward, no, we're not using DTI.
So was the reason you brought the patient back to do the elbow flexion imaging just to show that you can?
It's didactic. I never saw a snapping triceps on MRI, so.
Okay, well, These are wonderful cases. Thank you, everybody.
Yeah, thank you all. And well, we'll take a break for the next 2 months. Yes, July and August. And we will resume the activities on September 27th. Is that correct, Hillary? I think so.
I believe whatever you tell me.
Okay. See you. Bye-bye. Thank
Have a
you all.
good summer.
Bye.
Bye-bye.